Evening. Welcome back to the Ask Me Anything with Dr. Twyman. I'm a still board certified cardiologist after passing my board exam this weekend. The topic was electrophysiology. Not my expertise anymore since I left the hospital, but still something that I can do. So tonight we have some great questions as always. We answer them as we go. And if any comments have questions, we'll answer those as well. So hope you guys have had a great week, and we'll jump right on in tonight. So the first question of tonight is, what criteria do I use to determine a recommendation for a PCSK9 inhibitor? First, do you have dyslipidemia? Second, do you have atherosclerosis? 3, do you have any contraindications to taking statin therapy or other oral therapies? PCSK9s work very well, but if you have other option that is more cost effective and works well, then use that. The downsides of PCSK9s generally are just that they're injections, and that if insurance doesn't cover them, they used to be $15,000 a year, then $5,000 a year, and then as of this month, there's a direct-to-consumer option where you can get a path for about $250 cash, insurance not required. So cost is coming down on these drugs. So if somebody has an issue with their LD receptor, if they've done genetic testing, then it's probably really a slam dunk to use it. But typically, if people don't tolerate statins, or don't get to goals with statins and ezetimibe, then it's time to break out the PCSK9, particularly if they have elevated Lp(a). Next question of tonight, would estrogen in a woman 20 years post-menopause be beneficial or contraindicated? Depends on why you're considering estrogen therapy. The major benefit is during perimenopause and the beginning part of menopause when estrogen levels are dropping. So estrogen for a woman is beneficial for bone health, brain health, but from a vascular standpoint, it does have effect on the lipoproteins. Typically, the LDL cholesterol starts to increase, the HDL cholesterol tends to decrease, and there's often associated endothelial dysfunction where patients have issues with nitric oxide. So it may be beneficial at this stage. Contraindications mainly are based off of GYN issues. If you have a history or family history of breast cancer or ovarian cancer, then you're definitely a no-go with these things. But from a vascular standpoint, it's possibly beneficial, but not the main reason somebody should start hormone therapy. Next question up tonight, does saturated fat have a role in cardiovascular disease? The big answer is possibly. It is not, definitive, and it is not in every individual. Tends to be the patients with ApoE4 alleles, or if they do more advanced testing when they have issues with lipoprotein lipase, then they may have issues where saturated fat affects their LDL receptors and their lipoproteins increase. But that does not happen in everybody. I think the numbers are reported around 20% of people will have that kind of response. This is what you will tend to see in the people who are, quote, lean mass hyperresponders. So if you look at your ApoE genotype, if you have access to a Boston Heart diagnostic panel, you can look at the fatty acid balance test and see how much saturated fat you're getting in your diet, and you can have an idea should you be cutting back on saturated fat. But most people, test, don't guess. You don't have to cut saturated fat unless you have a significant bump up in your lipoproteins. Can vitamin B problems cause cardiovascular disease? I'll take this as, do you have an issue with methylation? If you have an MTHFR mutation, then possibly having low B vitamins and elevated homocysteine can increase the risk of cardiovascular disease. Mostly that it affects homocysteine, which then affects asymmetric dimethylarginine, which then affects nitric oxide. So for people who have this defect in their methylation pathways, then methylated B complexes sometimes will be beneficial. Next question, LAD calcium 644. This is a high risk finding. The HDL is in the 60s, the LDL cholesterol is in the 1-teens. How to lower the LDL? So, just to be frank, with that high risk of a calcium score test, you should consider pharmaceutical interventions with statins, ezetimibe, PCSK9 inhibitors. Exercise is excellent to help with blood pressure control, nitric oxide availability, decrease the risk of metabolic disease, decrease the risk of dementia. But exercise in of itself is not going to treat your dyslipidemia, and you're going to be more aggressive. Next question. With increasing age, there's a greater chance for heart and vascular problems. How and why? The immune system doesn't work as well. Nitric oxide pathways, including endothelial nitric oxide synthase enzymes, don't work as well. So the vascular system ages just like your joints, your skin age. So age is one of the biggest predictors of vascular disease. And I was recently at an AI conference that there are new technologies looking at EKGs that can assess your age of your vascular system just off your EKG, and it's pretty interesting technology, and hopefully have it coming to Apollo Cardiology in the very near future. Next question up tonight: can I discuss when to use incandescent lights versus red lights in the home? So the short answer is you should try to live by nature's rules. The sun is out, lights can be on. The sun is down, should have fire or red light. That's the best way to think about it. Incandescent light bulbs still are a circadian disruptor. They're less bad than the heavily blue spectrum LEDs and compact fluorescents, but they still disrupt the circadian rhythms as the blue photons of light hit the melanopsin receptors in the eyes and affect your circadian rhythms. So use incandescent bulbs if you need to during the day, but in the evening it's generally better to be red light. Or at least wear your blue blockers and protect your melanopsin receptors in your eyes. Next question, can you strengthen your heart muscles? Will this improve the ejection fraction? So the ejection fraction is how much blood is pumped out of the left ventricle with each heartbeat. Normally this number should be between 55 and 70%. The heart is a muscle that's continuously pumping, generally 60 to 100 beats a minute. Can you strengthen the heart muscle? Yes, but you got to figure out what is causing the heart muscle to be weak in the beginning with. When you have a cardiomyopathy, it's either ischemic, you don't have enough blood flow to the heart, or non-ischemic. The first one, ischemic, due to blockages in the three major coronary arteries with microcirculation. Treat those if you need to. If it's non-ischemic, is it an issue with a autoimmune condition? Do you have do you have sarcoidosis? Do you have amyloidosis? Do you have a myocarditis? We have an infection in the heart. Why is the heart not strong? Try to remove those causes when possible. And then anything that improves the redox potential. So you want to improve the net negative charge in your mitochondria. So grounding, sun exposure, sauna, red light therapy, cold exposure therapy may improve. There's Dr. Sinatra's awesome foursome cocktail that helps potentially with energy production in the mitochondria. So definitely there's ways to improve your ejection fraction. What is the best test for blocked arteries without contrast? Failed a treadmill. Is MRI suitable? 0 calcium. Okay, so the person says that they have Graves' disease. So you have to know that, is Graves' disease been treated, or are you having a thyroid storm? If you're having a thyroid storm, then you do need to avoid iodide contrast. If Graves' disease is a remote history and not active, you can be treated with methimazole if needed and get IV contrast if it is required, based off of what your symptoms are. Why did you have a stress test? Calcium score of 0 does not indicate that you do not have plaque. 8% of the time people have plaque in their arteries with a calcium score of 0. And you can still have severe 70 to 80% stenosis in the coronary arteries with a calcium score of 0. It's less likely, but still possible, I should say. So symptoms trump whatever a calcium score test shows. MRIs are generally not well suited to look at coronary arteries. They're more suited to look at the left ventricle function and also the right ventricular size and fatty infiltration if present. So if you're having symptoms and you had a failed stress test because you had symptoms that led you to get the stress test, then you need to talk to the doctor who ordered the test and talk about an invasive cardiac catheterization or a CT coronary angiogram. And if you have a history of Graves, then potentially may need to be pre-treated with methimazole. Next question, is a ezetimibe rest and stress test safe? They failed the treadmill. They have shortness of breath on exercise. Person has a calcium score of 0. It's a very well validated test to look for ischemia, looking at areas of the heart with less than ideal blood flow. So if your stress test is abnormal, then that still leads people to either optimize medical therapy or having an invasive angiogram to quantify the degree of stenosis in the coronary arteries. Again, symptoms trump a calcium score of 0. Okay, I think it's more of a comment, but okay. I have heard that people who are metabolically fit but have high LDL live longer. What are my thoughts? So this is a topic I've talked about on many podcasts in the past, but it is one of the things where it does depend on where you pick the data from. So there are octogenarians that have high LDL, and there's ones that have low. I can give you a personal example. So, N-of-1 analogies don't always mean anything. My great-grandmother Ola, for those who've been following for a long time, know that I'm trying to beat her longevity record. She was 106 years old when she passed away in 2000. Her LDL cholesterol was probably 40 milligrams per deciliter. She had loss of function PCSK9. She lived 106 with no vascular disease, never had a heart attack, didn't have to take any medications. If she had high LDL, would she live to 106? Unknown. So it is depending on what the person is potentially having as other comorbidities. If you have low LDL because you have an autoimmune condition or you have cancer, then you're not going to do well long term. So it depends on if the person is on medical therapy to treat their LDL, yes or no. In an ideal world, you are going to be generally more metabolically fit, not insulin resistant. So it really comes down to the health of the endothelium and the glycocalyx, the lining of the arteries, how much oxidative stress and inflammation you have, and the lipids play a role, but they are not the primary driver of vascular disease or longevity. And then the last pre-submitted question tonight, somebody says that the labs on 117-year-olds who died showed high LDL. Tried to bury it in a paper, might hurt the narrative. Again, I don't know the exact details of this one. High LDL doesn't mean you automatically get plaque in arteries. It's, I always use the analogy in my office with my patients, shots on goal. More shots, more potentially some get through. If you have a outstanding endothelial glycocalyx in endothelium, you can have familial hyperlipidemia and not develop plaque in your arteries. So it just shows you LDL is part of the equation in some individuals, but this person probably is doing a lot of other things that are right. And to be 117 years old, you generally have genes that affect your immune function and also have things that really reduce the risk that you get cancer at an earlier age. All right, so that is the pre-submitted questions tonight. Thank you guys, as always, for them. They're always entertaining and also helpful for everybody else who hears this information. Just checking out the comments. I know there's a question that has popped up. Somebody says that they unfortunately had a heart attack with sky-high troponin values. Troponin is a protein inside heart cells. If the heart cells die, the troponin is spilled out into the blood. The higher the troponin, generally the larger the heart attack. Could this possibly have damaged the heart muscles? It is a sign that the heart muscles are damaged. And can it repair naturally? It depends on what you mean by naturally, but in my previous question, things that improve redox potential. So getting grounding, sun exposure, potentially red light therapy, sauna therapy, possibly cold therapy, depending on other factors. Things that improve your mitochondrial function potentially have an improvement, but don't throw out Western medicine. There's still things that can be done that improve weak hearts from a Western medicine standpoint. That's why I don't like to be pigeonholed to say that I'm a functional medicine doctor or a quantum medicine or alternative therapy. I don't like any of those terms particularly. I like the word integrative. Use the best of all therapies. So if Western medicine works best for somebody with the least effect, use that. If it's a nutritional, functional standpoint, use that. If it's light water magnetism, quantum, use that. Use the tool that works for the patient. And then I think somebody just submitted a question. So let's see, I'll pull it up on the screen here. So how to reset the vagus nerve. I don't know what you mean by reset because the vagus nerve is always working. It's in balance with the sympathetic nervous system. So you may be asking, how do you improve vagal tone? Meditation, deep breathing exercises, biofeedback, grounding, Those are some of the things just off the top of my head. There are vagal nerve stimulators that can be utilized. The Pulsetto is a device. The Apollo Neuro is a device. You activate the vagus nerve, that lowers inflammation, slows the heart rate down. All right. So waiting for a few more questions to come in. So while we're doing that, the housekeeping is, I passed my boards. Yay for me. Now I got my time back. So I'm going to be putting some more content in my school community. I was recently at a Mayo Clinic AI Cardiology conference, which was outstanding. Their AI EKG platform is amazing. There's software that's out there that there's an app being developed that you can talk to, and it will tell you if you have aortic stenosis or if you have atrial fibrillation by the reverberations of your blood in the aorta that then get transmitted to your vocal cords that AI can hear. Pretty crazy stuff coming down the road. So in the next week or two, I'm going to be getting some demos for some of these devices and seeing which ones I'm going to bring into Apollo Cardiology. Fascinating device, which, I can't remember the name of it off the top of my head, but it's a device that sits on the chest wall. You put it on for 10 minutes. It can listen to flow in the coronary arteries. And it's mostly being utilized in emergency rooms to tell people who come in with chest pain, is it likely that they have coronary stenosis or it's another thing that's causing their chest pain? So looking to get a demo of that device and see if it makes sense to bring that into Apollo. All right, so another question popped up. Somebody says that they'd recently heard that Guggul and Amla can be natural remedies for lowering cholesterol and Ayurvedic practice. Have I heard of this? I've seen some patients utilize these. I've not seen great effects of the lipoproteins with this. This is something that, I have some patients that will do certain nutraceuticals or supplements, but it's one of those things, test, don't guess. So get yourself a Boston Heart Lab panel, Cleveland Heart Lab panel, look at your lipoproteins, look at the LDL particle, look at ApoB. If you have access to the cholesterol balance test from Boston Heart Lab, then you can understand, is it more of an issue with a hyperproduction marker or a hyperabsorption marker? If it is, then you might know that these supplements may work. Most of them, some of them might mimic what statins do, blocking HMG co-reductase. They block the enzyme that produces cholesterol in the liver. So think of it as a faucet that you're dialing it back. If they work well enough for you and get you to your goals that yourself and your doctor want, great, have at it. But if not, then use something that's more potent. And then somebody's giving us a thank out for myself and my team. So thank you for following us, and thank you for coming to St. Louis and being one of our people that we're working with to reverse and stabilize cardiovascular issues for them. So lucky that you found us. Instagram is one of the places I've been most active on social media since 2019. I'm also on YouTube and many podcasts. So I really do enjoy educating. In Apollo, I'm doing one-to-one in my school community, and here doing one-to-many. And eventually with my AI ideas that I have for the future, it's going to get pretty interesting having AI agents helping me educate people further and wide than I can just do one-on-one. So I appreciate your guys' time and attention this evening. You guys ask great questions, and always, every Monday, 6 p.m. Central Time, we do this again and answer your questions. So Monday morning, I put it in my stories, the Q&A box. So if you have a question that you want me to answer, put it there. Those questions get answered first. If there's still time, and there usually is, you can put a question in the comments, and I'll try to answer those as well. So I see one other question just popped in here. I'll answer this one, and then I'll send you guys on your way tonight. So somebody says that they're a 55-year-old female, a year into menopause. They have very low hormones. Their dad had a heart attack at the age of 73, and the mother has been on statins since the age of 65. Let's see. This calcium score. So sometimes in Instagram world, things don't continue, and we get them put onto another screen. So I don't know if you had a calcium score done or, okay, calcium score is no symptoms. Should I get it checked out? So if somebody has a calcium score of 0 but has a family history, that's a good sign. But you still may want to look at, do you have an LPA level that's elevated? 20% of the population has elevated LPA, which is the number one genetically inherited cholesterol particle that increases risk of vascular disease. Look at your ApoB level. Generally still should shoot for 70, even if you have a calcium score of 0. And if you're asking about the hormones, for the most part, as long as you don't have a family history of breast cancer or other reproductive cancers, and you're interested in hormone therapy, you do not appear to be at increased risk to consider hormone therapy. But the main benefit for estrogen particularly is for bone health and brain function. And then somebody put in one other question pre-submitted. So what are cardiologists looking for in a cardiac MRI? So this is actually top of mind because there's a lot of questions about cardiac MRIs on my recent board exam this past weekend. So most cardiologists don't read their own MRIs. It's generally going to be a radiologist. Some cardiologists will read these, but cardiac MRIs are mostly looking for the function of the myocardium, the muscle itself in the left ventricle. If you have a weak heart, if you have suspicion for myocarditis and inflammation in the heart, the cardiac MRI can help determine that. If you have an autoimmune condition such as sarcoidosis, you'll be able to see patchy late ganglionium enhancement in the myocardium. If you have arrhythmogenic right ventricle, you can see that on a cardiac MRI. It's also very sensitive at looking at valvular regurgitation, how much blood is leaking across certain valves. Cardiac MRI is not that great at looking at coronary arteries, though. That's better suited for a CT. But that's what they're mostly looking at for cardiac MRIs. If you have a weak heart or you have a significant valve issue that's not well seen on an echocardiogram. All right, guys. Well, I hope you enjoyed that one. If so, share with your friends. We're always trying to find more people who are interested in optimizing their health and trying to become more heart attack proof. So have a great week, and we'll see you next Monday.